familiar. And number three, getting people to understand what it is when a stroke occurs so that they can immediately have someone like Nurse Kathy was for me or themselves and respond. Now, what we did with, if I can work this thing right, probably can't. What we did immediately is we went in, and there were no, again, even at that time, 2 years later, there were no certified stroke centers. But JCO in Chicago and one of the local hospitals, they were very adamant about trying to get a certified stroke center. So we went to work with JCO, and we went to work with this hospital. And fortunately, it was time, and we got that hospital certified. First one in California. It's a primary stroke center. And we're very proud of that. The second one, short time later, was Stanford. So we got out of our goals immediately, we got 2 certified hospitals in place in Santa Clara County, the heart of Silicon Valley. Then we wanted to work on the redirection because we didn't want to go to the closest hospital with a stroke victim. We wanted to go to the right hospital. It turns out that the Board of Supervisors, who were very concerned about liability, we were able, after 2.5 years of very hard work, to get them to accept redirection so that the ambulance system would take stroke victims only to those certified stroke centers. They voted 5-0, unanimous vote to do so. Made a huge difference. Within about, there we go, well, let's see if I can, within, uh-oh. I'll just keep talking. There you go. Within about a year and a half, we went from 2 certified stroke centers to 10. Every hospital became a certified stroke center. And it was really interesting because not only that, we had a member of our board who was very active around the Bay and went to Alameda County, San Mateo County, San Francisco County, Contra Costa County, pushing the fact of what we had done in Santa Clara and asking, and he was a stroke victim as well, to do the same. It just worked like crazy, and we got certified stroke centers started popping up all over. Everybody was ready. It was marvelous. So in the Bay Area, we have, if I have my counts right, we have 29 certified stroke centers, including Monterey and Santa Cruz. And we're very, very proud of that. And then in California now, we have 177 certified stroke centers. I've always said if you're going to have a stroke anywhere in the United States or anywhere in the world, the place to have it is in the Bay Area. Now the redirection. We got the redirection for the primary in the very beginning. It made a big difference in stroke care in our county. Then comprehensive stroke centers came in a few years ago, and we happen to have kind of 3.5 comprehensive stroke centers now in Santa Clara County. And last year we went before the Board of Supervisors again and asked for redirection in the case of those stroke victims who can't really get help in a primary certified stroke center to be able to be immediately directed to a comprehensive. They voted 5-0 to do that, and that's in place now in our county for both the comprehensive and the primary. On the public outreach side was the third part because I didn't recognize the signs of stroke. What we've done are a couple things. One, we spent over $2.5 million already in the last 15 years. Full page ads, websites, Facebook, stroke walks. Red Cross is a partner of ours down there in getting the information out to the people about what to look for with a stroke. We went one step farther, and we created this in 2015, what was voted one of the 10 best medical apps in the United States, a stroke app. It's free, it's on our website, and this stroke app does a number of things. One, it identifies the signs of stroke so you can see it. Number two, it'll identify, if you're having a stroke, you can hit the button there, the red one, it'll go right to 911, and by the way, 11% of the thousands of these that are in place last year hit the 911 button. It identifies if you do hit that button, your emergency contacts that are already listed in the app will immediately be notified so they know you're having a stroke. And this has already played out in some experiences already. And the last one, the bottom, is my favorite, quite frankly, and that is anywhere in the United States of America, including Hawaii and Alaska, you hit that button, it will tell you the closest certified stroke centers to where you're standing or you're sitting at that particular point in time. I don't care whether you're in New York, Beloit, Wisconsin, Biloxi, Mississippi, Seattle, Washington. It'll tell you the closest certified stroke centers, because not all parts of the country have redirection in their ambulance policies like we do here in the Bay Area. So that has been very helpful. Now, the results. I'm just going to show you a couple slides, and I will sit down and get out of your hair. But these two slides to me tell me a lot about what's happened now in Santa Clara County. And these are Santa Clara County Department of Health Services statistics. And that right here is the ischemic stroke patient arrival in less than 3.5 hours. You can see in 2015, we were running at 28, 29%. In the last probably year and a half, now it's going up to 55% because all these things are kicking in now, including our stroke app. The next one is the use of TPA. When I received TPA and researched it, both with Dr. Albers and Raj Bhandari from Kaiser and all these, it was 1.2 to 1.8% was a percentage across the country. Now we're between 17 and 18%. We're rising, and we want to see that even go higher. So as another result, these things are working, and they are working certainly in our community, and we're very, very proud of it. I guess the last thing, I have some interesting examples of how this has helped friends of mine over the years, personal friends, and a number of them. I'll pass on that, but I will say in conclusion that thank you very much for having me here. We do speeches a lot with the foundation and our board members to try to tell everybody what we've been able to accomplish, and if there's anything that would help them or any of you in doing anything along these lines or helping us do a better job, we're most interested in doing that. And because I'm standing here, the only reason with Nurse Kathy and what they did and the health system of this country did for me, this is, I guess, my simple way of trying to give some back. So thank you very much for your patience.
So I came to university relatively late in my career and didn't really know much about teaching. But one of the things you get taught in the teacher's course is to engage your students and not just talk at them. So I got a question for you coming up, as I have in the past, and it specifically relates to what the panel is going to talk about. If you think about what it would take to kind of identify and then put into effect the major missed opportunities to favorably affect the health trajectories and health spending trajectories of populations. You know, there are a number of jobs to be done. First, you have to get clear, distill out, you know, what you should be doing, where the leverage points are, and what does it imply in terms of change in clinical practice. That's what our fellows have done. The second thing you have to do is you have to figure out how you get clinicians who are habituated to doing things a certain way to accept the evidence and make change. And in our panel this morning, we're going to hear from Jeff Klingman from the Permanente medical group here in Northern California, and Kaiser Permanente more broadly, who's one of these people who saw a big opportunity once the baton had been handed from the EMTs to the emergency room, to do something very different. You know, he attended one of Hattie's prior events, heard our fellows talk about the fact that in America, where having a door-to-needle time before you put the TPA into the right patient of less than 60 minutes was considered good, our fellows, as they scanned the global literature, figured out that Helsinki was doing it in 17 minutes, and if you multiply that by the number of dead brain cells per minute, it makes a material difference in how many disabling strokes you end up with versus non-disabling strokes. But you know, getting that information out is probably 10% of the work. 90% of the work is actually getting clinicians to change how they do their work, and that is a very uncertain and stressful path. But Jeff did a phenomenal job of making that happen quickly within the hospitals here in Kaiser Permanente in Northern California. And we're going to ask him to talk about that. The second thing that makes all of this so hard is that there's this engine of evidence generation that keeps publishing results that says, well, now we've tried something different in American healthcare, and so now what previously was optimal is no longer optimal. And here we are, you've gone through agony to change, clinician practice, and now something comes along that you find, a trial comes along you find persuasive, and now you have to decide what you're going to tell your clinicians. And Nirali Vora from Stanford is going to talk about something that's just became very visible in the year since we've last yet met, that actually perhaps implies some changes in what we've been advocating here at these meetings. And she's going to help you kind of understand what, if any, change it implies as to what happens once those EMTs hand the baton to the clinicians. All right, so let's move forward. So here's the question. Over the last year, there have been a number of clinical trials that showed that new advances in endovascular therapy, taking a catheter with a little corkscrew on the end and pulling the clot out of the brain, that extend the stroke treatment window, the window where you can actually get a full recovery, to almost 24 hours, no longer 3 hours or less. And so here's the question for you. Some of you are probably understand both of the relevant trials. Some of you may have vaguely heard of them, and some of you have not heard of them. So now's your quiz, no matter what group you're in. So the question is, based on your best understanding of what you know about this, which of these three answers is right? One is, hey, it's a freaking nightmare to try to get this done in 17 minutes. Most hospitals who hear about it can't get it done. Thank goodness we don't have to worry about that anymore, because now we have a 24-hour window. Second opportunity is, well, wait a minute, let's get sensible here. That Helsinki trial, the endovascular trial didn't necessarily apply to all stroke patients. Let's at least not sweat it for the patients for whom this endovascular therapy has been shown to be effective. And the third option is, forget about this trial stuff. Just keep sweating the minutes and try to see if some American health system can actually meet or beat the 17 minutes that's routine in Helsinki. Okay? Those are your three choices. So you have these voting machines, on your tables. So you vote for, is it ABC? Is that how it's laid out? Or 1, 2, 3? Yeah, okay, ABC. Okay. I'll give you 5 more seconds. Okay. No, do I press the button and we see what the audience answers? That's right, yeah. The upper button. Right button, okay. So it's the distribution. Okay.
Don't feel so bad.
It's keep doing it for everybody. Now, of course, to keep you engaged, I'm not going to tell you what the right answer is. For that, you have to hear from our panelists. So which of you two would like to begin?
There we go. So yeah, what happened was, I'm going to give you a little history lesson. We're at a university. We're next to Berkeley, so we're going to start with history. Stroke Express program was developed. We named it because it sounds a lot cooler that way. It stands for Expediting Process of Evaluating and Stopping Stroke, and I always disclose no alcohol was involved in coming up with that name. But what we did was he sort of said, and this actually started, as was mentioned, right after the endovascular trials came out in 2015, and we had by the end of 2016 the new process in place. So a little bit of history. So prior to the onset of IV alteplase, stroke treatment was you push the patient in the back of the emergency room because there really wasn't much to offer. So this is what was the standard treatment. Back in those days, neurologists were known for admiring rather than treating diseases. In 1996, the NINDS trial came along showing IV alteplase and was effective in less than 3 hours. And you can see dramatically improved outcomes if you look at various measures. In all cases, people that get rapid IV alteplase do better than those that don't. But this wasn't quickly taken up. There was a lot of concern among emergency rooms, doctors around risks and so on. And so when we hear from Chuck, this was a slow uptake on this actual treatment, even though it was available in 1996. And then what happened, but it didn't take very many. Number needed to treat of only 4, which is a very impressive number. This was to prevent a big disability, very impressive number for somebody that's already had a stroke. But it's very time sensitive, and so you really want to treat quickly. People have tried to extend the window, kind of got stretched out to 4.5 hours, but faster is better in all cases. And this is kind of looking at the fact that it is very time sensitive. The number needed to treat in 0 to 1.5 hours is 3.6. Number needed to harm is 65. But by the time you get beyond 4.5 hours, you actually are getting to the point where it's easier to harm than to benefit. So time is very critical for IV alteplase treatment in acute stroke. The sooner you can do it, the better, basically. Now, what about endovascular treatment? Because we heard from Artie that we've got a window out to 24 hours. These are the biggest strokes. What about that? Well, I remember being at the International Stroke Conference in 2013. There were a lot of long faces among device manufacturers. 3 different studies showed no benefit to endovascular treatment. And there's a couple of reasons for that. One of them is that they were older devices that weren't quite as effective, but the bigger reason has to do with patient selection. It's all about patient selection. All patients do not benefit from endovascular treatment. You need to do IV alteplase, pick the ones that benefit, and that's the key. So this was the sad faces among the device manufacturers. 2016, the world changed once again, and there were 4 different studies presented demonstrating that in selected patients, endovascular treatment after IV alteplase is an effective treatment, and in the window up to 6 hours, so between 4.5 and 6 hours where IV alteplase is not an option, endovascular treatment works with really impressive numbers needed to treat. The lowest one with the 7 was basically the Mr. Clean study that was done in the Netherlands, and that was pretty non-selective. That was if you had a stroke and you had an occlusion, you did better. If there's a large vessel occlusion and you go to endovascular treatment. But it's still time sensitive, and that's important to recognize. And the other thing that's super important to recognize is that this is a minimal number of people. So most people are still going to benefit from the IV alteplase. Way more people get treated, and I'll present some data that I presented at this year's International Stroke Conference to highlight that. And the difference between 2013, again, was primarily patient selection. So here's what happened this year. For those of you that don't know, every 3 years, apparently the stroke world blows up and starts over, and this is what happened. This year, 2 studies were presented, and what happened uniquely this year is that the authors of the studies were in contact with the Heart Association guidelines people. The guidelines changed one day after publication of the study, which is a real challenge. Suddenly, standard of care has changed. There's 2 studies that were done. Dawn looked at 6 to 24 hours, people that were independent at baseline. Large strokes in Dawn, NIHSS of greater than 10. They all had occlusions, and they had a relatively small core area of stroke. Diffuse was somewhat different. It only went out to 16 hours. They allowed slightly more disability, but not much, basically still independent. NIHSS of 6 or greater, and there was some mismatch. This was largely CT perfusion. So it's technically very different in terms of how you look at these strokes compared to what we were doing before. Now we need advanced imaging to say that this is still a large area of brain to be preserved, because in many cases, large vessel occlusion equals large stroke that doesn't benefit from treatment. So we sort of asked back in 2015 after the 2016, after the initial stroke, what would it take to get to that world-class door-to-needle time? And the reason we asked it wasn't just because it's better to do faster, it was also we wanted to build time to be able to get CT angiograms. If you're at a center that doesn't have endovascular capability, get them out the door. There's still a role for primary stroke centers to get these people identified, but you got to treat them quickly. And we wanted to build an additional 30 plus minutes to be able to transfer and build in rapid transfer processes. And so we said, well, what do we do? And we weren't at that point routinely doing CT angiograms on everyone. Why would you? There's no accepted treatment before that. Suddenly there is. So we redesigned the whole world. So, you know, Kaiser Northern California is a huge geographic area. We got lots and lots of doctors. And we knew from some of the data that's been done that some of the keys to quickly treating patients are to get them all evaluated by a stroke neurologist at the door. That really does drive performance. The problem is I got 21 certified stroke hospitals. I can't have a neurologist in the door all the time. So for us, the solution was we popped the neurologist on the video screen. So every one of our strokes now that are acute strokes are evaluated by a remote teleneurologist on video. And what that allows us to do is to greet the patient at the door. So everybody that comes in is greeted at the door by the teleneurologist. Ideally, they call me en route on transport. And so I'm actually able to greet them at the door. This happened at Redwood City on Tuesday, got a notification from EMS, patient showed up. We evaluate them right there in the ambulance bay. If you room a patient, it takes 15 minutes. Watch it sometime if you don't believe it, but rooming is a time sink. It doesn't add value, so we see them right there. We actually redesigned the process and we told everyone where to stand. So nurse 1 stands here, nurse 2 stands here, ED tech stands here, ED doc stands here, and everybody's got their role. Who's putting which IV in, who's doing the weight. The teleneurologist does the exam and discussion with the ED doc. The teleneurologist actually orders the alteplase, which the ED docs love, all designed to eliminate steps. We used to check labs. We realized the labs never changed anything. Why are we doing it? We stopped doing labs. The next thing is they go down to CT scan. As soon as the CT is done, because we've ordered the alteplase before we need it in the ambulance bay, unless there's a CT contraindication, as soon as it's done, we're ready to push the drug. So guy on Tuesday, for example, had uncontrolled hypertension. We had to push labetalol. We had to start nicardipine. We had to get the blood pressure down. Still treated him within 25 minutes, even with all of that, because everything was ready to go. And then basically everybody gets a CT angiogram. Why not? Why would we try to select it? We find that there are small strokes that still have large vessel occlusions, so we do that. And then we also have really worked on a rapid transfer process because we are going to, why not work on that? You've got a lot of these centers. And we actually order the ambulance at the time they arrive. So we've already ordered the CCT rig in that first 5 minutes when we're mixing the alteplase, so that if they show up in 30 minutes, they're ready to leave as soon as we've got the CT angiogram performed. And so we get them out. We've got a goal of door in, door out, 60 minutes or less, which includes treatment, advanced imaging, contact, the whole bit. So we don't really lose any time. This was published in Stroke in January, if anybody wants to read all the gory details. Now, one thing that's unique about this is we get that video neurologist to see everybody right at the beginning. And the other thing we did when we put this in place is we put in a standardized note that's got little hashtags in it so we can go back and rapidly collect the data. Because we said, well, we need to figure out how we're doing to track this down, which was kind of a pretty smart thing because now it allows us to build a database pretty quickly. And it includes whether they had a large vessel occlusion, where we sent them, what the NIHSS was. So it gives us a lot of information. So this is kind of the outcomes. So before we started Stroke Express, we did pretty well. We were about 63% in less than 60 minutes, which gets you a lot of awards and accolades from the Heart Association, but it's not the best in the world, as we heard. After implementation, we get our door-to-needle time down to basically about a half an hour or so. It was, I think, 34 minutes in this particular case, but it's continued to decline since then, and that includes pretty much all comers. So you're allowed to exclude uncontrolled hypertension in your bragging rights and so on. This includes everybody. We also found a dramatic increase in the number of alteplase administrations because now you've got stroke neurologists involved in making that decision. The ED docs don't have to be reluctant. They've got to, we're standing there arm in arm making that decision. So we basically have the time to treatment and doubled the rate. And we did this at all 21 facilities. Basically, as soon as the implementation took place, we had this dramatic improvement. The next thing that happened, so it had been in place for a bit, and folks are saying we can't possibly change the target. And I said, well, really, why not? And they said, well, you can't get beyond 30 minutes. That's like crazy. You can't do that. And I said, yeah, we can. We can. At the time, it was 45 minutes. And I said, why don't we do it 30 minutes? We're almost there now. Why live with 30 minutes and 45 minutes? Because the Heart Association best standard is 50% of the time within 45 minutes. And so we said, no, we're going to go for 30. And so, that's what measured gets done. So we were able to continue to improve. So at this point, the last time I looked, we were holding at about 70% in less than a half an hour. So here's your question, because this gets to the second part. Because now we know that there's this endovascular treatment. So here's the question. More patients are eligible for treatment with IV alteplase than treated with endovascular therapy. That's a true-false question. People are pretty fast. There you go. I think we're almost there. And so I go for the next slide, right? Okay, we've got a few non-believers. We'll talk to you about that. This is actually the next presentation. So this is what came out of when we looked at our data across Northern California. This is really interesting. You won't find this anywhere else because nowhere else are all the strokes met by a neurologist. That's one of the things we have. Most places ED screens them out and they'll never call the neurologist, so most of your databases don't look at the great group because we do. So we got called for 2,500 patients that were brought in by ambulance. There were about 5,000 total because half of people walk in, something else to keep in mind. And what we found is that actually of those, about half actually had strokes, which is okay. We want paramedics to cast a wide net. We want them to pick up stroke mimics, but sometimes they also miss the last time known well. The other night I saw somebody, eyes were deviated to the left-sided weakness. Unless you're a geeky neurologist, you don't understand that that's not a stroke, it's a seizure. And that's the sign of thing that having a neurologist there makes a big difference. He had a little bit of twitching in his left hand, his eyes are looking to the left, that's the wrong direction. And so we know it's a seizure. That's an example of that. We also see a lot of sepsis patients come in because they're confused. So about half the time paramedics clinically are right. Now of those, we found that about half of them had large strokes. So this is an NIHSS cutoff of 8 or above is sort of a good cutoff number for whether it's likely they have a large vessel occlusion. This mimics some of the paramedic developed scales that have been out there. And so really about half the people. So this would be your target group if you were going to say, can paramedics decide who to send to the stroke center? And of those, we found that 141 of them ended up actually needing large vessel occlusion treatment. So when you're designing your system, you have to think about that. 5.5% of the total population ends up with large vessel occlusion. So the answer to the question is, it's still super important to identify patients for endovascular treatment, and it's a relatively small number, even of the large vessel occlusions that benefit. And so as I look at that, looking at the entire system, my take on it is still focus on rapid treatment, require the primary centers to treat them rapidly, and focus on rapid transfer because it benefits everybody. And that's one of the things that sort of gets lost in the conversation. So about 600 were treated with alteplase, 4 times as many as endovascular. So that's why that is super important. Don't forget, even though we're now in an extended window, it's still important that time is brain. We don't know how many will qualify for treatment in the extended window. It's probably a small number. There was one study that just got published last week, which I didn't even have time to put up, that said 1.7% of people in the 6 to 24 hours ended up being potential candidates for clot extraction. Or actually not even for clot extraction, just for Dawn criteria. And nobody's really looked at it, but Extend IA kind of looked at advanced imaging and found that it was a relatively small